Good evening, everybody. I'm delighted to be invited to talk tonight, and huge thank you for joining us in this absolutely beautiful evening, because it's an evening that I suppose we rarely see such sunshine. And thank you, Una. That's a very hard act to follow. You did great, and thank you for kicking off tonight. Um, Thanks to especially to Beth and the team, because without her, this just wouldn't happen. And of course, Eleanor, who's instrumental at getting us all going and looking at research into T21, which is a really passionate cause for me. I'm going to tell you tonight a bit of a story and a little bit of a history and bring you through, I suppose, our own experience in our own department. So I'm an adolescent and paediatric rheumatologist, and I'm based at CHI, Crumlin, and I also do some adolescent work in St. Vincent's. So I'm there about 20 years, and my interest in arthritis with T21 began with my training in the UK, because I came across a good few children there, and I've realised that nobody was really looking after this condition, and there was very little known about it. So I'm just going to go right back to the past. So many of us know that it was Langdon that first described T21 or Down syndrome back in 1866. And he described a lot of the clinical features that many of you would be aware of, the typical face and some of the muscle findings, as well as many know the single palmar crease. So the description of some of the characteristics with T21 were described a long time ago, but very little was mentioned about the joint and muscles, or the musculoskeletal system. And some of the first references were back in 1984, when a condition was described as arthropathy. So arthropathy kind of means damage to the joints. So there was a description in 84 of a couple of cases of arthropathy of Down syndrome, but that was really the first reference that we could find. But it didn't really, I suppose, highlight that this is very much an inflammatory condition rather than a disorder or poor growth in the joints. And when we were starting off this journey, and a lot of my research started with Dr. Charlene Foley, who's back working with us in London now, we went back looking to see for historical references, and we found this photograph, which was one really in the 1800s. And if you zoom in closely, when we looked, we could actually see there's actually early evidence of arthritis in the fingers of this girl way back, but there was never any reference to it. But so this is the first clinical photography of a condition now that we now refer to and is accepted worldwide as Down syndrome associated arthritis. So, like many things, a lot of conversations start in the corridor, but arthritis in children is otherwise known as JIA, or juvenile idiopathic arthritis. So I'll say juvenile arthritis for short. And any cases that we had seen or that I had experienced, all these children were referred to having juvenile arthritis. But we had concerns, myself and my team, that maybe it actually wasn't the same condition. So our story began in Crumlin, and one of the questions we were wondering was, and what I suppose our hypothesis was that this is more than a random association between arthritis and Down syndrome. And we felt there actually was a much higher incidence and prevalence. So the condition was commoner than what was actually reported in the literature up to that point. We felt that the diagnosis was really not being picked up. There was a delay compared to juvenile arthritis. And these are things that we had a sense of, but we had no proof, if you know what I mean. So that's why we decided we'd have to look into research further. And then we were seeing sometimes lots of damage. We were seeing some people coming in where we saw the joints were damaged, there was poor growth, or the joints were restricted. So we would call them flexion deformities. And this said to us, gosh, there could really be a missed opportunity here to treat and get in early and to describe this condition. And hence, really, from about 2012, 15 onwards, Charlene and myself led a study where we looked at musculoskeletal problems in children with T21, and 503 children were examined as part of that study. And some of those children had already been part of our department. But many of you know the first thing people say when they think about muscle and joint problems is that people worry about the neck. Everyone thinks about C-spine instability, but in fact, that's actually not that common, and it's only about 1%, and that's actually what we saw in our study as well. But actually, the commonest thing that we actually found was arthritis. Inflammatory arthritis was in 7% of these 500 children that we examined. And these examinations took place in our own department, but Charlene also went out to some of the centres around the country, and some of you here might have met her on the road at that time. So we also picked up other things like a higher risk of scoliosis and kneecap instability and things like that. So in that original study, what we found is that actually arthritis with T21 or arthritis with Down syndrome was 20 times more common than juvenile arthritis or JIA, and actually over 2 times more common than what was reported in research or literature up to that point. And we published that back in 2019. We also found that the time to diagnosis, so we compared our new patients with T21 arthritis with new patients with juvenile arthritis, and as we expected, the children with T21 arthritis, there was a delay for diagnosis, and the route to getting a diagnosis was harder and was mainly through the research. Though this was telling us then that there was really not as much awareness. So most of the cases of T21 arthritis were picked up because of our study, not because the patients were being sent in or that people were thinking about it out in the community or in primary care. So what about joints? What kind of joints were involved? Well, knees are usually the commonest joint, but what we found in our study is that there was a lot of little involvement of the fingers and toes. So we call that small joint involvement, and it was much more common in children with T21 arthritis. We also found when we looked at x-rays and radiology, it was more damaging. So erosions are little nibbles in the articular cartilage in your joints, and that's called damage. And that's a real sign that arthritis can be very inflammatory and damaging. So we found more damage on x-ray in these children. We also found some other problems much more commoner than we would have seen compared to the group who we recruited for juvenile arthritis at the same time. So this kind of confirmed a little bit what we had suspected and what our hypothesis was before we started it. So just bringing you back, that very first study in, I suppose it's now over 10 years ago, confirmed that arthritis was more common, and we have now published that the prevalence is 1 in 50 or 20 in 1,000. We know the reasons for delays is multifactorial, and this is something we wanted to explore more. And even the type of arthritis was very much small joints. And we were seeing psoriasis. So many of you know that psoriasis is a skin condition, but it's actually also autoimmune. And arthritis is autoimmune. So this made us think, this immune system is not happy. And we knew that the immune system can be dysregulated or not functioning well in some people, particularly with T21. So that gave us another clue. So we were always looking out for things like psoriasis, and often in the scalp it will start. But a lot of our children would develop psoriasis after the joints, but some of them even beforehand. But we saw this also, that this arthritis was happening in children with T21 across all ages, even as young as under 1, which was quite rare in children with juvenile arthritis. And there was a lot of damage. So as a result, in 2019, we decided that this really term of arthropathy needed to go, and we need to say this really is an inflammatory picture, or itis. We all know, like appendicitis, it means inflammation. And we wanted it out there that this is definitely an arthritis, and it's aggressive. So we rephrased the term DA. We thought it was easy to remember. So we call it as Down syndrome associated arthritis. And we backed up this by doing some more detailed studies. We got into the lab, and working here actually with Ursula Farong and TCD and her wonderful team, we were able to show that there was lots of evidence to say that it was much more inflammatory and erosive. So we looked at little protein molecules, or cytokines, and T cells. So these guys are big drivers of inflammation in the immune system. And we looked at it in fluid from the joint, and particularly in blood. We were also fortunate enough to get a little piece of a sample of the inside of the joint, or a synovial biopsy, in some patients. And that really, really supported this huge inflammation that was going on, and loads of increased, I suppose, metabolism and blood flow in the area, supporting a really, really strong inflammatory picture. And we also got better at describing what we were seeing. So we were seeing subtle changes. These children weren't getting big, huge swellings like knees or big ankle joints. They were getting subtle. Most of them would get subtle symptoms. And we were always getting some patients where we had seen advanced disease. But in the beginning, the arthritis was not big, buggy swelling, but more subtle swelling. I don't know if I have a pointer there, but you might actually just see around those little, is that a pointer? Yeah, it might be. I'll just try that. So you might just be able to see around the little fingers, the middle joints here, you can see some swelling of what we call the PIP joints, or the PIP joints. So the swelling is subtle, but certainly there. So bringing you up to where we are at the present, well, in these few years, awareness has hugely improved. And in fact, I have to say wholeheartedly, that's down to Beth, T21 arthritis research, and actually you guys as parents. And that's, I suppose, media and social platforms where people are making each other aware of it. So I have lots of patients coming now because they've heard about arthritis and T21, and they're asking their GPs and asking to be referred if they've concerns. So awareness is hugely, hugely improving. We're not seeing late diagnosis anymore. And I didn't put this up because I didn't actually want to frighten anybody or scare you, but this is a picture of one of our patients who came very late to us. And you can see that we've got lots of stuck joints or bent joints, and there's bends in the knees there, and flexion deformity or bends in the elbows, and many joints that are stuck or flexion deformities. So that's really important to watch out that we catch this condition early. So we thankfully are not seeing as many conditions like that anymore. We're in a very unique position because two things: we've got great research going on, but we also have nearly all patients will go through only CHI. So we're in a really good position to be able to look at this in much more detail, because we're not depending on lot of our patients going through lots of different services. Most of our patients can go through one service, and we can capture as many people with this condition. And now we have nearly over 400 patients with this condition. So the biggest cohort in the world from what we know. One big area that we're really trying to think a bit more about is transition, because our adult colleagues are not seeing these patients, but they're graduating. So this is an area that's passionate to us at the moment about transition. And I do work as an adolescent rheumatologist too, but transition for children with DA is slightly different and needs a lot more planning. So that's something I might refer back to later on. But we need to think about our adult patients with DA, because although the awareness has increased in the pediatric side, adults with trisomy 21 do have this too, and may have had it for much, much longer than children. So signs and symptoms, well, there's typical symptoms of pain or swelling may be absent or reduced. And as I say, the symptoms can be very subtle. So pain isn't an actually reliable marker, and that's something that we feel and we know, but we really need to show in evidence, and that's one of our work we're looking at. But some of the more leading questions I would ask when I consider this condition is there a change? For instance, was John walking to school last year and now he sits down 3 times? Is he less inclined to go out on the trampoline? So a change in the baseline, or a loss in stamina, or sometimes even behaviour, because some people might report that they think that their child is upset or they're more crosser. So even change in behaviour, it may well, not saying it is, but it was a possibility, could be pain, and to consider that. So loss in exercise tolerance, poor stamina, or a change. Biting and chewing of fingers, we know that fingers and toes are involved. We don't know if chewing and biting is a sign, because we know our children with T10, T1 sometimes can be quite sensory, but that's something we are exploring. But early research is showing us that that's not a definite sign, but we do always consider it. So the diagnosis, I said, was challenging. Here is a big knee, and I think nearly everybody in this room would see and wouldn't miss that big swollen right knee. And that's a child with juvenile arthritis, and that's, most of us would pick up on that. But over on the other side here, there's one of our children's with DA, and they've got a swollen right knee. And interesting, you can see the hand is resting on the affected knee. So it's subtle. We don't get big swelling, but we get loss of the bony contours. So it can be hard to pick up, and hard for our colleagues and clinicians and adult health professionals to pick up, because the signs can be very subtle. Yes. So I'm just going to show you a quick video, because I think it's very powerful showing you sometimes a patient, and I'm very grateful to Ava and her family for showing us this video of Ava, who was a patient of ours a few years ago. And I just want to show you what she was like coming down in the morning. We hit play here. Yes. Come on then, please. I'm trying. I know you are. Come on. Oh. Wait. I got it. Okay, come on then. Stand up straight, please. I'm trying. I know you're trying. Do your best. So you can see she's really struggling to get down the stairs here. And it was first thing in the morning, so she's probably quite stiff as well. Morning stiffness is something we'll be looking out for. Yes. Come on then. I can. Yes, you can. Stand up, please. You've done that far. Just watch while she's holding the wrist there. She doesn't mention it, but she's rubbing the wrist. Come on, darling. Quick as you can. Take Ultra's hand, please. Now, stand up again. Ava, stand up, please. Okay. Good girl. Come on. Hold on to the banister. Yeah. That's it. So a simple thing like coming down the stairs becomes a huge process. So one thing I just want you to see there is that despite all this, our lovely Ava is smiling. Yeah, and throughout that, we had a very happy, I suppose you would think, demeanor, but we know she's actually in pain. So I mentioned about the challenges and delay in diagnosis, and hence why we really wanted to look at what were the potential barriers to getting a diagnosis, or why were these children not coming to services earlier on? Definitely lack of awareness is something we all know about, and I referred to that earlier. But pain expression and verbal skills may be impaired. Often parents with T21 say that they have a high pain tolerance or there's a delayed response. And I think you've all experienced that. I'm looking at our original study, 91% of our children in that first study were either non-verbal or had poor language skills. So that is a barrier. And some may have coexistent other conditions like ASD, autistic spectrum disorder. But only 9% of families or clinicians did suspect the diagnosis before they came to us. There can be a gradual loss of time and hence an adaptation. So watch out for that. There will be a functional change, there can be behavioural problems. And there can be a regression or a change in milestones. And obviously coexistent intellectual disability can impair reporting. And then of course they're so bendy, hypermobile. And of course they are often able to do party tricks with their legs or fingers and get into positions none of us could even dream of. So being hypermobile often sometimes is a barrier because people think the range of movement is so good. Okay. But these are some of the many challenges that face in terms of a diagnosis. And that's one thing I will always ask when I meet somebody is, why are you in a wheelchair? Or what's the reason for a wheelchair? I think we should never accept we're in a wheelchair because we've got T21. So just diagnosing this can be tricky, and in some cases we need to do imaging such as MRI, and many of you have seen an MRI before, but it's a big machine that makes a bit of noise, but sometimes with a headphone and a bit of music it can distract you, and it takes about an hour, but it's a good procedure for picking up information. And this is an MRI of a wrist. You might see that really bright bit here at the wrist, and that is showing us inflammation in the carpus or the wrist bones, and it lights up beautifully with dye. But there's also potentially other ways that we could pick up this earlier, and I'm going to refer to this earlier, but other procedures and modalities are ultrasound. Many of you would have heard of ultrasound before. So treatments I'm going to touch on briefly because I know I'm probably a little bit nearly over time at this stage. I'm going to get into trouble. So treatments, I suppose the good news story here is there's lots of treatments and we're using these. This is the present. We avoid the bread and butter methotrexate because our children with T21 are very sick on it. But we're very fortunate that we've really good access to special drugs called biologics and now JAK inhibitors. And these are little molecules in your blood system that are, I suppose, that these drugs counteract. So they would sometimes bind to them or they block their action and then they decrease the inflammation in the system. Most of our medicines are by pens, but in recent times, the new JAK inhibitors are tablets. So this has been brilliant for our families. So rather than having to give an injection home or infusion, we now have some treatments that are tablets twice a day. So this has been brilliant in recent years. So the future, well, I want to say it is good and things are getting hugely better. I wanted to show you Ava here after about 4 months of treatment on one of those medicines, adalimumab, Humira that I just showed you. I don't know if that projects well. Can you see that?
Relax. Sorry. Do some exercise this morning. Shake your legs, let's see you. Great. The other one. Jump up and down. You are a super girl.
Welcome. So you can see that is absolutely day and night, and she had a beautiful response to medication and is doing very well. I'm very grateful for her, for our mum for showing us, and Ulton, the big brother, for bringing her down the stairs. So I want to just briefly mention what's going on in the future and what's happening in our department at the moment. We've just recently got funded for a registry, and this will be our first opportunity to build a framework and describing juvenile arthritis. And part of that, we're going to be describing DA, or Down syndrome associated arthritis. And this is going to be done electronically by a REDCap platform. So we're super excited about this because this allows us to look at research and data in other centres worldwide and compare directly, and to have a very, I suppose, streamlined way of collecting information for the future. So this is something for some of you who come to our department, you're hearing more and more about. But it allow us to engage parents, and we have parents and families involved, helping us ask the questions that we want to know. But we're hoping to be able to start this very soon. So we're looking at arthritis in DA and in juvenile arthritis. So I want to tell you also too about ultrasound. I mentioned that as potentially a modality for looking at arthritis because MRI can take a while to get, and some children, as you know, need to be put asleep to have an MRI to stay still, and that delays treatment. Now, not everybody needs an MRI, but sometimes it is very helpful for diagnosing when this condition can be subtle. So ultrasound is something that we're looking at. It takes a good while to train up, but we're very fortunate. We have Jeremy here, who's our research fellow, and he's here tonight, who has just been very successful in getting an ultrasound machine funded through the HSC through a Spark innovation. And he's going to be driving and moving us all forward and training on that over the next couple of years. But this is exciting because it's something that we can do at the bedside. And we had a trial run there only about 2 weeks ago with our wonderful Owen and his mum, Rosemary, who might be here with us today. And it was a great success. I think Owen loved it, and it was great interaction, able to see what's happening. So this is something that we're hugely excited about over the next while. And then just to mention too, our CEDA study, which is really what Dermot is going to be doing now as our research fellow and our MD student. And he's doing his MD through UCD and working here with our collaboration with TCD and Ursula Ferron and her immunology lab, and also with Great Ormond Street. And we're going to be looking at lots of things, expanding on the first study we did back in 2015, but we're going into much more detail now, looking at those T cells and looking at cytokines, which are these little proteins that push inflammation. And we're also going to be looking at all these processes in the fluid in joints as well. So we'll be looking and asking you to help us out. We won't be taking anything extra, because when we do joint injections in theatre, we usually, if we take some fluid out of a joint, we put it in the bin. But this time we'll be asking you, can we hold on to it to look at it under the microscope in great detail? And we'll be also asking for 2 teaspoons of blood when you're having normal bloods taken. So it'll be nothing extra, but it'll be alongside your normal care. So we'll be grateful for your support of the study. And I think this is going to be really open up a huge opportunity for us to find specific treatments that could change this for people long term, that we will have a very targeted treatment. So huge excitement around this, and we're delighted to have Dermot as the backbone there. So finally, I'm sorry because I have gone over, all I want to say, this is really the tip of the iceberg. We're really only scratching at the surface. We're only really starting to describe this condition. This is worldwide, affects all ethnic groups, and very little is known about it. So we're have a lot to do and a lot more to do, but it's all about collaboration. And it's because of forums like this, and it's because of reaching out to other centres that we can get this work done. And it's most of all, it's because of you guys that we can make healthcare better and give more targeted treatments and better outcomes. So huge thanks to you all. I hope I didn't ramble on too much, and happy to take a few questions later on. Okay, thank you. Want to do questions now? Yeah. Okay. Yeah.
Sorry.
You want to do the online?
No.
Online? Oh, yeah.
Oh, yeah,
Right,
no,
yeah.
we're not doing online questions. No,
Okay.
just going to do questions
Yeah.
in the room.
Thanks, Jane.
There's roving mics. Any questions?
Thank you for, I suppose, speaking and I suppose educating us on this. My question is, how do you decide in terms of medication who's more suitable for one? When do you move on to another one?
Yeah.
Kind of thing?
That's a really good question. So I suppose we kind of practice what we do with juvenile arthritis, and we always kind of international practice would be if you had 4 or more swollen, what we call active joints, you need to be treated systemically by a medication, so it hits everywhere. But if you only had 1 joint, sometimes we would try a little joint injection. So you could see that picture of the synovial fluid. So sometimes children will tolerate that with some laughing gas or Entonox, but sometimes we have to do that by a brief anaesthetic in theatre. So if it only 1 or 2 joints, we'd probably try that first. But sometimes they may need systemic treatment. But we don't use methotrexate anymore because we know our children got quite sick on it. But we're very lucky. We have very good access to these drugs called biologics in Ireland. And we can prescribe and get them within days, which is wonderful.
Okay. Thank you very much.
I think, Orla, it's different from the NHS and experiences in other sites for access to biologics.
Yeah, very much so. Like in the UK and other countries, you have to do an awful lot of paperwork, and sometimes they will make you try methotrexate first and have to fail it. So yeah, we're very fortunate. I suppose we do like to moan sometimes about our health system, but there's other perks and other ways that it functions very well. So that's one thing we're very fortunate about. Yeah, yeah. No. There's no other centre that would have as many patients, you see. And I suppose we're unique in the sense that we're national service. So you'll find we have a unit in Kansas in the States that do quite a bit of work, but they don't have a huge number of patients. They collate a lot of their information from multiple centres. But we would definitely have the biggest number of patients worldwide, yeah. Yeah.
just hit me. It's
Yeah.
so recent.
Yes, exactly.
Thank you.
Yeah, yeah.
And so-
And so new, yeah.
so
But if you look back, I mean, if you look at that photograph, I think it's just fascinating, you know, that photograph is what, 150 years maybe, you know, and it was always there. Yeah, 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 yeah. I think there's often been an acceptance, you know, that because someone has Down syndrome, then their mobility is not going to be great, or, you know, they're not expected to walk for long. That's what, you know, it's just everything's put down to T21 rather than saying, well, why? What is the reason for not being able to? Yeah.
Bring just the side effects, the biologics really, like, and the risk, because a lot of our kids would have compromised immune
Yeah.
systems
Yes.
anyway.
Yes.
And then we're sort of adding a biologic in. So just is there much of a
That's a really good
risk?
question. And it's a little bit more causes anxiety than other people. But I suppose for any parent, starting them on any drug is a big issue, isn't it? But you're right, our children with Down syndrome have a natural state of a slightly lower immune system. And that's why those new molecules, JAKs, we don't use them as first or second line agents because we just don't have enough experience. They're only out in the last few years. So we reserve them for patients that have failed at least 3 biologics. And even when we give those JAK inhibitors, we give medicines to protect against infection that you take alongside it. So we do antivirals and antibiotics at the same time. Now, all in all, we've been very lucky. We have, thankfully, we've rarely had to stop because of infection, you know. But we take extra precaution and really close blood monitoring. Yeah, yeah.